I was asked today to join you guys to talk about clinical trials in obstetrics, which seems like it could be sort of like giant and then little and everything in between. So I thought that we would talk a little bit about multi-center clinical trials in obstetrics, and I would share some kind of pearls and regrets from the trenches. So thanks again for having me, and we'll see what we can figure out over this next short bit of time we have together. So I have no financial disclosures, which remains, I assume, sort of semi-regrettable. So if anybody has any suggestions for me, just throw them in the chat and I'll sort that out. When Yasser asked me to talk with us together and then sort of have some Q&A at the end, there was an idea that maybe I could talk a little bit about kind of what's under the hood, if you will, sort of, lift up the, front hood and see what's underneath and what sorts of things were sort of in there, but you can't see when you kind of read the paper about a trial or thinking about setting one up and so on and so forth. So I thought that over the time we have together, we'd talk about two trials serving as examples, knowing that our audience is a little bit mixed. So what these two trials are both some common things. So multi-center trials in the United States. So we're not going to talk about going beyond into international collaborations and things like that, which are incredibly important. We're just going to not tackle that in the next 30 minutes. And then both of these trials are pragmatic and obstetric centric. So, and pragmatic, we'll kind of talk about this a little bit along the way, but this tends to be sort of more of the work that I tend to do, which is, you randomize patients to one thing or another and that specific thing. But after that, all of the rest of their care is as one would be treated. And I find that not every question lends itself to that, but oftentimes a lot of the questions that I tend to sort of think about and ask do lend themselves to that. And then sort of what we find could be immediately translatable because, okay, they manage the rest of the labor the way that I would, or the way that is acceptable to me, and so forth. So we'll talk about the OMSS trial, which is the optimal management of second stage, and then a little bit about the COMFORT trial, which is less obvious and is a whole pile of words where people stole out sort of different letters and made that to be the COMFORT trial. So apparently that's legal now. So you can just sort of steal which letters come into something together. But we'll talk about each of those. And I thought that I'd highlight some things that were kind of maybe interesting or helpful or not known, and we'll see where we go. So the optimal management of second stage trial, or OMSS, why did we think that we should do this trial? So it fundamentally was set up to answer this specific question, which is when the second stage of labor is reached, so completely dilated, and that time of second stage completely dilated to delivering a baby, among those who have regional anesthesia, so epidurals most commonly, does pushing right away or delayed pushing result in better outcomes? And we don't have time tonight to talk about the data that led up to this, but there were several small single center studies that were of really kind of mixed quality and so forth that didn't quite answer what the answer to this, was potentially going to be for us. And then there was one very large multi-center trial that was conducted in Canada and was incredibly well done, but was over 2 decades old and really represented obstetric practice that no longer happened in the US. So this question was, for women without regional anesthesia, when they become completely dilated, all of us who practice clinical obstetrics know they push right away. You don't have to tell them or teach them or coach them or whatever. That's just sort of an instinctive thing. Whereas if you give somebody regional anesthesia and they're comfortable, should we allow the uterus to contract and contract and contract and do all this work while people rest? So that was the central kind of question in the backdrop of why this came to be. So I'm asked sometimes about funding, so I thought I'd weave this in here. I mean, it's never nice to talk about money, but it does actually make these things happen. So I thought that I'd mention just a little bit about this. So this trial was funded ultimately by the NICHD, and it was in a U01 mechanism. And sometimes people look at that sort of crediting and ask me kind of what does that mean? You know, why would that be? And this was through what's called the large grant mechanism in the NIH and especially for NICHD. And so how you go about that is you say, so the largest R01 that you can apply for is of direct funding, $500,000 a year for 5 years. And you say, well, I think I have this important question and I want to ask it, but to ask and answer it the proper way, I need a little bit more money than that. So how would you go about doing that? So it is possible to actually get extra money to be able to do that. And essentially what you do, summarizing, is you kind of write your aims and you have a budget and you send those to your program officer and you work with them to kind of get those through, and they're reviewed internally, and ultimately the director of the institute signs off and gives you permission to apply. So there's no money there. It just is telling you you have permission to apply for extra money and we'll consider you. And then you apply for that grant through a normal kind of deadlines for a new R01 mechanism. So that's how you did that. And this is the very first time that I did this. So I just thought that I would share with the group. So we sent in the first submission of this, and, you know, this is not meaning to be Debbie Downer at all, but I definitely kind of in my career have philosophically felt like it's probably not going to get the green light for the first go around. So what other things could we think about? You know, when we got to the 11th hour and we're submitting the grant, what other things did we feel like might be missing, or what sort of work could we do to get us closer to being able to do this? So there are a few things here that I wanted to sort of share that we thought about. So first, we actually decided to generate actual pilot data around equipoise. So if you think about it, right, we do randomized trials when we think that there's reasonable medical certainty to be uncertain. We're not sure if A or B is better. And so in this particular case, there were two different practices that were commonly used across the United States, and people thought that they were doing the best thing for sure. I lived this especially because I was trained in a place during residency where everybody pushed right away when they were completely dilated with an epidural. And then I moved to a place for fellowship where nobody did, and everybody was laboring down. And I had no idea what was going on. And everybody in both places told me, well, this is the way to do it. And, you know, I mean, that doesn't make any sense to a scientist. Like, how could that be right? So they might be equal, but both places can't be saying, well, this is the better way. So we decided to formally pilot providers of various, you know, levels. And we did it actually across the sites that we were planning to do the trial at. And this gave us an idea to be able to demonstrate in ultimately what was the resubmission that actually there was equipoise, because in general, across all the various sites, about the application was 50-50. And so we could say, you know, people were really torn. They didn't really know. The other thing that we did was we'd been working on a meta-analysis of the prior data, and we did that, you know, with a particular strategy. But just to say that I do think that this is an underutilized tool. And especially if you're a junior person and you can learn how to do this, this is really, really valuable because it's pretty cheap. And you become a true expert in the space of what you're, because you know all the data, because you have to know all the data. And then meta-analysis is actually considered true pilot data. So you don't have to sort of be saying, oh, I need, you know, the fish and the pictures and the other things or all this sort of stuff. You can actually show that meta-analysis of prior data are considered legitimate pilot data for your trial. And so I would just encourage people to learn to do this because it is really valuable. So we did that and we published that as a group because oftentimes that's a criticism. Your group is a new consortium. I've never worked at a place where I've been part of the network. So I was always creating my own networks, and how can we demonstrate that we can work together? Education was a giant one. So how do we convince, really this practice is happening a lot of times on labor and delivery. And so who's there? Our nurses, right? So how are we going to help them help us? How are we going to help them understand that this is actually a huge pressing issue? And it was actually the nurses at my two different training institutions that told me, like, A is right or B is right. So how are we going to kind of work through that to figure that out? And that was really incredibly worth it ultimately for me. And it's been a theme kind of for future studies. And then the last was that like then leads to finding champions. So I do think that it's really important to try and identify along the way people that are passionate about the work that you're about to do or embarking on or thinking about, because they really become these incredibly valuable members of the team that help bring everybody else along. So as I predicted, well, I didn't know that we would be scored and discussed, but regardless, we were not funded. But we got some feedback about what we proposed. And we really wanted to be super pragmatic. So prior studies, only one tiny trial had included in nullips and multips. And we really wanted to tackle everybody, because when I came to fellowship, it was being applied to everyone, even though really all of the data was about nullips. And the reviews were like, listen, it's really hard to mess up management of a multip in the second stage. I mean, they kind of almost can have a kid without you, no offense. So just sort of, this is not an issue for them. Really the majority of morbidity that we look at in term birth comes from nullips. So they were not interested in that. And we just had to kind of give that up. And that's one of those sort of, come to yourself moments where, do we want this to get funded, or, what are we going to decide that it's okay to give up? And then one of the things that we wanted to do was look at the pelvic floor, particularly of nullips, in the coming years after the management of labor, to see, I think that many of our pelvic floor colleagues feel like there are aspects of labor that result in morbidity. And I think there's always this sort of like, well, is it us, or is it, sort of what's the story here? So we really wanted to have a chance to look at that. And our reviewers liked that idea. They just wanted more of it. And so that really led to the trial being as expensive as it was. So anyway, second time around, we got the money, and so that was, super great. And this is sort of the end to sort of describe the beginning. But we were able to look at, do a randomized controlled trial of immediate pushing versus delayed pushing in nulliparous women receiving regional anesthesia. And looking at those sort of bullets there, we were really focused on improving the chance to improve spontaneous vaginal delivery. So there's obviously been this huge focus on our cesarean rates and what is optimal, but we think it's too high. And what does that mean? And probably it's sort of a multifactorial impact. And so are we going to find some ways to improve the spontaneous vaginal delivery rate, which we think is healthier for moms and babies? So that's what we were powered to look at. And then secondarily, we were also powered to look at maternal and neonatal morbidities. And then the last piece was this pelvic floor component, which we followed women through 3 years postpartum with imaging and other assessments. And the NIH really felt like that was particularly important to them, and the sort of relationship to the pelvic floor network, because this would be the largest prospective cohort that had been able to look at those sorts of things in a careful way forward going. So that's what happened next. So I wanted to mention something about approach consent and randomization as it relates to labor and delivery studies, because I think that this is not unique to obstetrics, but it is a little bit unique in the way that many trials are done. And I think that the approach is not inconsistent with kind of every other trial we think about, right? So everyone who's eligible should be approached, or should be thought about to be able to be approached. And I think that this particular issue, we want to challenge ourselves to be sure that we're finding a way to approach actually everybody that's eligible, because this is where some of the disparities in care and the way that we have gaps in care actually kind of cut out patient populations that are just very difficult to figure out how to approach them to be part of the study, but oftentimes they represent a lion's share of the morbidity. And then separating out these next two things, which is a little bit, I think, kind of foreign, but to many of you guys who are also experts in doing these sorts of studies, this stuff. So kind of consent and randomization and separating those out. So realistically, kind of for labor and delivery, this meant that, all nullips with an epidural or who were planning to have an epidural were approached to be consented and met all the other inclusion criteria, but they didn't quite have all the inclusion criteria yet to be randomized. And so this is important because, when you think about, this is essentially saying, okay, patients that are in the first stage of labor, they meet all of these criteria, but this is a second stage trial. So they haven't met criteria to enter the second stage. So they haven't met all the inclusion criteria yet. So you don't want to randomize them then, right? Because as we know, we want everything to follow intention to treat. And you start to drive your denominator if you consent and randomize them then, and then you have a big wedge of patients who are going to arrest in the first stage, and then they'll be sectioned. And you have a big wedge of patients who have concerning fetal parameters, and they'll be sectioned. And so all of those patients will never reach complete dilation, but you'll have randomized them, right? So you'll have sort of made a little bit of a mess after all this hard work for yourself. So we've taken this approach for many things, which is to sort of consent where there's much more time and no acuity and those sorts of things, to consent people to be in the study, but then to wait till they reach those last phases of inclusion criteria to kind of finalize that and randomize them. So that became an important construct that we used prior to this study, but I just wanted to bring it up because it's a little bit unique to the way kind of obstetric trials can work on labor and delivery. I wanted to show you this because this was the table 1 of the trial. So this is a figure that I find it very helpful when I'm planning and leading up to a trial to think about what the paper might look like you dream about the paper, but like the figures that are going to be in there and what you need to have. So how are we going to appropriately collect all of the things that are going to be on this page such that you can report these? Because everybody wants to know, right? Who's in, but also who's out. How did you kick them out? Did they, again, and you can see there that in that first cluster of 4963, the group that didn't meet inclusion criteria, that first giant chunk of like bits there are all patients. If you had randomized them at the time of consent, they would have sort of upended the trial, right? Because they all were patients who were going to sort of basically funnel off and never meet that final group because it's a second stage trial. So they never made it to the second stage. So you kind of can get some sense of what that looks like. And really the goal is in that bubble of randomized, as we all know, those two groups, those create your denominators, and you want really ideally everybody to be included in those denominators. The great news is for a lot of the work that I do that's on labor and delivery, it's hard to lose somebody on labor and delivery. If I start losing people, Yasser's going to like fly out to Texas and help rescue me. That'd be bad news. So the trial was stopped early. And so that leads me to probably talking about a next, I think, important really point that I wanted to make, which is your data safety and monitoring board. So I would say that these are really your allies. They are there to do exactly what that is described as, monitor the data and safety of the participants. But it's really helpful, I think, if you can challenge yourself to be thoughtful about who you want to have on your DSMB, because they really help inform your study of things they want to track, other outcomes they want measured, definitions of various outcomes. And so I think if you can try to think about these things, sometimes they feel like extras or add-ons, like, oh my gosh, we wrote the trial, we got the money, like, let's not worry about this thing. This group of people are incredibly helpful, I think, and really essential to the study. And if you can be proactive, you as the PI or you as your group of PIs, you're the best experts to say, these are the experts that we really want to be overlooking our trial and telling us whether or not this is going in the direction it should be or not. The expertise is usually a combination of things, but certainly content expertise and statistical expertise. So those are really important. And I highly recommend an odd number because they don't always agree and they need to vote. So odd numbers vote tiebreakers. So this is what happened to us. So, we hypothesized that women, if they pushed right away, would have a higher rate of spontaneous vaginal delivery because that's what women did if they didn't have an epidural. And we did not show that. So you can see our primary outcome, spontaneous vaginal delivery. So the number one reason that the DSMB wanted to shut down our study was for futility. So you can see the rates of spontaneous vaginal delivery are almost exactly the same between the two groups, with a relative risk of 0.99, which essentially said that, I'd be retired or maybe dead by the time this trial would be effectively over, showing any sort of difference. So and really showing us sort of analytically that not only was it futile and it could go on forever and be so enormous, but the degree of difference could be, we could acquire such an enormous sample size. Let's say we just expanded it to, we wouldn't do this, but let's just say for discussion's sake, we'd expand this to, a 50,000 person trial. And we found a degree of difference of, 0.3 between the two groups. Like, so, I mean, what do we really do that thinks that difference is really meaningful? So, so that was item number one. And then the next issue was for harm. So the DSMB was extremely concerned that there was some evidence that there was an increased risk of harm, both maternal and neonatal. And so you can kind of see with those arrows like going down there, the rates were low, but there was an significant increased risk of postpartum hemorrhage and chorioamnionitis for patients who were in the delayed pushing group. And this was the neonatal outcomes, and similarly an increased risk of a poor acidemia, poor cord gas, and confirmed or suspected sepsis. So my pearls and regrets from this trial were just to say, so I think that we spent a long time thinking about the team. We wanted to be regionally representative across the United States, and we wanted to have try to have sites that were managed differently. So labor and delivery floors that were primarily nurse managed or primarily, resident managed, or had, large midwifery groups or big private practices. And so we tried to be thoughtful about that. And so I think looking back, I'm proud of that. I think we spent a lot of time thinking about a lot of things that were not so smart, but I think that this was a helpful thing in terms of generalizability and things we learned along the way. I think the other thing that we knew from prior trials were to plan ahead for publication. So I mentioned sort of thinking in your mind, okay, about what that, table one, or figure one rather, looks like, and what you want to have in there. And what, if you were a consumer of the trial, what you'd be asking yourself, like, where did they go? Where were they lost? What, those sorts of things, to be able to collect those things. I think there were other things though. So, when you go to register your trial in a trial registry, there are a lot of things to upload. And that includes details of your analytic plan, and there's no room for budging. So really you want to be honed in on that to be sure. And I've found the most important time to think about those things are actually between when you have a score, you're going to get funded, and when funding is coming. Because you end up with this gap that the NIH sort of gives us because how the government functions, that's a different conversation. But just, so you end up with this gap. And it's really good to go back to everybody and say, like, hey, I know we wrote this grant, almost 2 years ago. But do we feel good about this? Because now's the time to revise this plan, augment it, change anything or what have you, because that gets uploaded to the registry. And if you didn't follow your own rules, then these types of places that you want to potentially publish a really important paper. And that's really what your impact is going to be, could be influenced by that. So not to give you another thing to worry about, but just that is a super important one. And then regrets. So, well, there's always sort of a load of regrets, but a couple things just to mention. So data collection. So, I would say that primary data collection is so precious when you have these sorts of resources that can allow you to go into charts and look at things or what have you. I try and think of it, I try and sort of stretch my brain, and it's always not stretched far enough, but try and stretch my brain in terms of what other things do we want to collect, not just for this study, but what other things do we want to do? Do we want to also have people that are involved in this study potentially sign a waiver to be approached for future studies? Do we want to collect data that are, do we want to have offshoots? Do we want to understand patient experience data? I think that it's good time to really stretch your mind and talk to other people that have done, some similar works, just to say, or read what they've, and sort of, oh, wow, they asked patients in the postpartum period about X, Y, or Z. I think that can be really helpful. And then I didn't know at the time how sad I would feel about the fact that we didn't think about implementation, because this seemed like the regular way that we would do trials in obstetrics at the time, and this is old now, like when we started this. And it was, we would just get the money and do the trial. And then this had pelvic floor follow-up. So that was kind of unique, but generally speaking, then people would apply for another grant to do follow-up. But the study wasn't set up to be able to do that in a careful way. And for me, it wasn't really set up to figure out how we implement what we find. So I came from these two different places, right, where they were doing these two totally polar opposite things. And then we had these findings. And so, like, how are you going to, like, influence practice in one direction or the other, whatever it might be? And I started getting, calls to give grand rounds. And it was like, oh my gosh, like, this is what I'm going to do. This is the rest of my life. The rest of my life is like giving grand rounds about this, like, one specific thing, because I like go and they're like, we can't get anybody to stop doing X, or we can't get anybody to start doing Y. And I just realized there are other ways to think about that scientifically and how you would kind of go forward and do that. Okay, so I'm going to switch gears here and just briefly talk about the COMFORT trial. So again, this is a sort of a why one. So this trial, so OMSS is done, obviously, and the follow-up is done, and the work of the follow-up is being published. This is a study in progress. So this was set up to ask kind of two things. One, is it effective and safe to begin cervical ripening in nullips who are getting an induction as an outpatient with a Foley balloon? And then whether or not it is or is not. So whatever we find, how can we best implement that into practice? So obviously prior experiences are affecting my next thing. But that's what the COMFORT trial is about. And I'll tell you, there are a couple of small studies that were done before this study in the US, looking at outpatient ripening. None were powered for hard efficacy or safety. So what I mean by hard efficacy is like things that we think are most tangential to or most related to morbidity. So mode of delivery, et cetera, et cetera. And then asking whether or not it's safe. And that's always sort of being a big deal. So that's really unanswered. And we really thought that was important to do because, of course, during COVID, kind of everybody was trying to figure out how can we help patients get care in a potentially more safe environment. But these key questions we thought were important to answer before we move in some direction in a large way, and obviously implementation. So the design of this trial is like a little bit different than trials I've done before. And there are these hybrids that I just wanted to kind of highlight, and you can see them all there. But the idea is that you sort of, if you imagine like an aims page, you essentially have the same aims that you would always have for an effectiveness or a comparative effectiveness trial. You would just additionally have one or more aims that are about implementation. And so the COMFORT trial is a type 1 hybrid, which essentially is we're randomizing patients, inpatient or outpatient initiation of their NULIPs, initiating their induction. And then we're gathering a bunch of information about implementation pre and post or what have you, with the idea that we could make faster progress that has been done before. And this is just a more traditional funding mechanism. There's a bunch of pre-trial work here. So education, same theme. So nursing and other folks feeling like they feel comfortable. They feel like we have enough data to say this is okay, or, we're going to it's okay to have patients randomized to either arm. We didn't talk about a lot of logistics, but there is, worthwhile to have I have an enormous checklist of, kind of logistics of regulatory things that are everything, every data collection form, every way that we go about that. There's single site IRB now, data coordinating center rather is happening here at UT. So that was kind of a first time for me to open a trial in this way. The registry we've talked a little bit about, but there's just kind of a ton to do, feeling like kind of this endless list. And then we had some real logistical things. So where we talked about the OMSS trial, which was just 2 accepted sort of standard of care, randomized between them and kind of happening real time. This was not the case in some of the sites. In our site, we were kind of like, how do we do this? I mean, we didn't do any outpatient ripening. So how do we do this? In other sites that are in the trial, they were doing this, but there was this pressure to feel like, well, it's not evidence-based. We don't have any safety data. How do we even counsel these patients? They had to shut that down, figure out how to put people into the study. And so for us, we did a pilot of volunteers. So we just asked for volunteers that were willing to be part of an outpatient sort of registry. And we tried to figure out ways to incorporate how we rolled them into the study to reduce post-randomization loss. So that's a theme you'll hear. And then kind of where do we place this? How do we monitor them? How does billing work? Like a lot of kind of crazy things. And then, of course, we were challenged on both sides with induction slots on labor and delivery. And then, patients told us a lot. Why were they willing to be in the pilot? We did a lot with them to help us develop brochures and flyers for the study. We actually wrote into the trial funding to do a patient video that's bilingual, that was informed by patients. It's sort of like a cartoon. So that's been very interesting, but we're also studying that to figure out whether or not that was helpful. And this is really a pragmatic trial of NULIP. So I'm not going to sort of dwell on this, but just it excluded patients that you wouldn't feel comfortable sending home, but everybody else you'd feel okay for them to come home the next day if otherwise things looked good. And from an implementation perspective, we really wanted to better our understanding. And so that's been ongoing. So we kind of gathered a ton of survey information from providers. The patient understanding is ongoing. And the idea that whatever we come out with on the other side will be better equipped to inform kind of how we move forward with better practice. And so this opened in May of 2023, and this is kind of what it looks like. We bring patients in, we examine them, they meet the final criteria, then they get randomized, then they are assigned to inpatient versus outpatient, and then they kind of come back to see us for delivery. So last little bit here, pearls and regrets. So again, team. So we tried to spend a lot of time thinking about our team. I think that that's been really incredibly worthwhile for us. Also for the team that interacts with the patients, that's been huge. And I feel like for this study, the prep was big. So doing some pilot work and figuring out how to functionally do some of these things is totally fine to do. And it doesn't ruin your trial, and it doesn't take away from, patients that are going to be enrolled in your trial, but it helps. And then regrets, I'm sure I'll have many, but ask me in a few years, since we're just a little bit into this. So hopefully I didn't go too long. I want to thank you guys for having me, and very happy to hear questions or comments, but appreciate you having me with you tonight.
Alison, thank you so much. This was such a nice review, not only of the studies, but kind of the peek under the hood and of the challenges. And there's several questions in the chat, and I'm sure more coming in. So I'll just start with what's in the chat here. Ron Gibbs says, thank you for the excellent presentation. This is for the second stage trial. Was the increase in chorioamnionitis seen in delayed pushing group due to cases occurring in second stage?
Oh, that is a great question. Patients were, that's a great question. Patients were censored at the time of delivery. So we haven't actually looked at that, but that'd be an interesting thing to look at. I would say that the rates overall, you saw that there was statistically significant differences, but the rates overall were pretty low, as you might expect. I think that it probably is a little bit more the fact that length of all of labor is collinear with risk of chorio. So I'm guessing that those probably went together a little bit. And the delayed group had a longer second stage, but had a longer length of labor. But it's a great question. We haven't looked at it. So that's a great question for one of my residents to get after.
Great. And Deirdre Lyle asks, can you comment more about how specifically you would think about implementation in advance for OMSS?
Yeah, thanks, Deirdre. Good to see you. Gosh, I'm not sure. I think that I think now, having talked a fair amount about it, it had been so ingrained in practice in one direction or another with sort of like these true believers that I don't really think that the question of whether or not it was better one way or another was really relevant to so many people. And I actually wonder if we should have done much broader education, because watching what happened in our microcosm of our various sites and kind of educating around that and having people feel like, oh, wow, I didn't really realize that, or, oh, I didn't really realize that's what that looked like. It almost makes you feel like we lost an opportunity for maybe webinars or other types of pre-educational things to sort of say, this is a little bit up in the air, to try and sort of pre-adjust practice to not be so dogmatic that we knew that this is the way, this is the way of life. I don't know. That's sort of the kind of almost easiest one, because we just made so much progress doing that sort of work. I know it's something that people feel really passionate about. So I've definitely learned that for sure.
Alison, Yair Blumenfeld says, awesome talk, Alison, as usual. How do you think about generalizability of the study outside academic medical centers during the study design phase? And do you think about generalizability of the study outside the US? Yair, I assume you're taught which study specifically, both just in general?
Yeah, this is a more global question. As you design a trial Are you thinking about, obviously the bulk of the work is done in academic medical centers. Do you think during the design phase, okay, how is this going to be applied to non-academic centers, and does that change study design? And do you also think maybe generalizability internationally?
Yeah, thanks, Ayer, and good to hear your voice. So I think kind of both. I mean, I don't think that there can be any shortage of trying to think through these things. I'll take them sort of maybe separately. So as it relates to sort of US wise, we tried to really be thoughtful about this in terms of OMSS. So I think we had community hospitals involved, and we had centers that had huge midwifery practices, and we did that very purposefully. And then for comfort, as an example, our site here, we're sort of consciously representing a couple of demographics. So one is a particularly huge underserved Latinx population that's not really represented anywhere else, with a very different kind of like philosophical and other types of things. And then our practice structure here on labor and delivery, our main site, which does about 6,000 deliveries a year, where, this is majority happening, has, 3 enormous private practices, which are largely, private run or what have you. So we have tried to be thoughtful about that. I think the key is describing that so that when everybody else reads the study, they don't feel like, oh, this is just another sort of conglomerate of, the 5 besties of whatever, and not really representing different ways that obstetrics are practiced. In terms of internationally, I feel like that's a huge challenge. And I totally agree with the point that you're making, I think, which is, should it be thought of in design? I totally think so. And I think for international studies, I feel like when I get into these types of discussions, I'm so ignorant as to how obstetrics is being practiced in other places that I think that we really need to understand so much more about what that looks like before we decide, okay, we're going to design a trial and it's somehow going to be extrapolated to X place or Y place, because that's just not how they practice. But I think the key is in the design phase, 100%.
Yeah, thanks.
Alison, we have a comment here from Anna Gerson. Amazing talk. Can you tell us more about the education, in quotes, that you did as part of your pre-work? How can you educate without influencing the clinical management before a trial?
Yeah, that's a great question. So that's really tough, right? So you kind of want to thread that needle, because there's been some data before what you're going to do. So that data shouldn't feel like non-information, right? That is information. We just are seeking to get better information. So I think that trying to do your best to be thoughtful about what that information sounds like. So for us, for example, for OMSS, it was, when you guys decide to have a patient labor down, you guys want the best outcomes, right? And so the thing is, though, that we don't have a big enough study to tell us that how they do is better. We also don't have something that says that we know that they do worse. So you're not doing something harmful, but we don't know yet that we're doing something better. So let's try and figure out how we can do this study and figure out how we can do whatever it is that's better. So it's a little bit more of that. So it's a little bit nuanced. And you're exactly right. It's a little bit, it's sensitive for people who feel really strongly. I mean, I was the resident nut, at the place where I did fellowship, and then, went on to stay on and was sort of trying to describe to people, well, we don't actually know that, laboring down is a great idea. I mean, they thought I was insane. Donuts help. Meetings with donuts. I don't know.
I'm wondering on that same theme, the outpatient Foley,
Yeah.
because that also tends to have people who feel very strongly. And my personal concern has always been the absence of safety data. I mean, one prolapse port in the living room, and we're in a different place about this approach. How did you talk to the sites that were using this routinely?
Yeah, that's a great question, Yasser. I think that we asked them what they were telling patients. And then we tried to sort of kind of dance into that a little bit and say, well, they may like it better, like you're saying, but they might not. But they could be part of this study and we could figure that out. I think the hardest thing I think that in general, it's been so rare for me that when you get down to brass tacks, patients or providers are irrational about what they want to do for their patients. I mean, they want to do the best thing. So I think that if you can find a way to kind of talk to them and help them realize, we don't really have any safety. So if they ask you about that, is this safe? You can't actually say yes, because we don't actually know that. You can say we don't know. That would be truthful. But you could have them be part of this and that sort of stuff. So I think that's been that actually has been surprised. It's been a huge surprise to me. I thought that the huge private practices here that kind of, want to do their thing, and some providers do this regularly, would not be excited to be part of this. And I was totally wrong. That was an ignorant assumption on my part. And they actually feel super passionate. No one feels excited that I can't tell them the answer for 3 years, but all of them feel super excited. And there was this original thought that well, there are private patients, we want to be able to place their Foley or what have you. So we made all these sort of ways that could be possible. And it's pragmatic, so anybody can place the Foley. But when it came down to brass tacks, once again, we had this sort of well-lubed system that we did through the pilot. And they're like, yep, patient signed up. They're going to come, they're going to do their thing, fill out their survey. They're in or they're out, inpatient or outpatient. I'll see them the next morning. Terrific. Mm-hmm. Thank you so much. So I actually feel like I brought my own preconceptions on what that was going to be like, especially changing institutions, 4.5 years ago. But it's actually been, it's been great.
Thank you so much, Alison. I'll ask the last question in the minute that we are over here, but
Sorry.
It seems so much of this comes down to implementation and implementation science. For folks who are interested in a career conducting clinical trials, would you advise some kind of formal training on implementation science?
I think it's a good idea just to feel like you can speak the language. Mm-hmm. I don't think that people need these advanced degrees and all sorts of these things. I mean, Yasser, you and I have talked about this 1,000 times, but for the rest of the group, I don't really feel like, I kind of grew up in a time where I got another degree because if you didn't have an MD and a PhD, no one would take you seriously and you didn't have any chops. So I got another degree because of that. But looking back, I don't think I really needed letters. I mean, I really needed the tools in the toolbox. And so I think that, implementation and dissemination is extraordinarily important, and we've underestimated the importance of that for some time. I don't think that you need to be some card-carrying whatever, but I do think that you need to have some things in your wheelhouse, some things in your in your toolbox where you might take an online, you could do an intensive weekend course, you could do an intensive summer week. You don't have to, have advanced degrees in this, because people do. And it's really emerging, and especially in our field, I mean, there are very few kind of experts in it, if you will. But I think knowing, like, just having some awareness that this is a real barrier to what we discover.
Mhm.
So we do all this work. OMSS costs $9 million in directs, right? So we do all that work. They're not going to fund another trial. That's like, and it's, you like it or you don't like it. I'm up for all the criticisms, but like, that's what we got, right? So then it's sort of, well, we didn't really plan for implementation and how that's going to work. So I think that knowing kind of what the limits are, what other things you want to do, and being able to phone a friend, so I don't think you have to be an expert in everything, but I think knowing, like just knowing that, my own biostatistical training gets, I can think outside of the scope of what I can do. So then that's when I know I need to phone a friend. So I think it's a little bit of that myself.
Alison, thank you so much. This has just been absolutely insightful and wonderful, as always, and we are so grateful for you to be here and to be our keynote speaker. And I know it's late where you're at, but please, if you have nothing better to do this evening, stay on with us. But if not, thank you so much again.